Hello friends, I am Dr. Anjali Sharma, Director COE Oncopathology at Dr. Bila's Lab Jaipur. Today we'll be discussing about the dysplastic villous adenoma. Why I have chosen this topic? Because they account for 5 to 10% of all detected adenomatous polyps, and their malignant potential is disproportionately high in comparison to the other adenomas. And the progression pathway that they follow, that is the classical adenoma to carcinoma sequence driven by the sequential genetic hits, that is mutation in the APC, KRAS and TP53. And the size also matters because if the more than 2 centimeter size, it carries a risk of approximately 35 to 50% of having invasive adenocarcinoma at the time of discovery. So this is the case that we received, and you can see that it's a beautiful endoscopic picture where approximately 3 centimeter size polyp is there. And this is a 70-year-old gentleman. He came with a complaint of altered bowel habits. And on endoscopy, this was found in the rectum, 3 centimeter pedunculated mass, and it was a friable. It was having a friable surface, and all the larger rectal polyps, more than 2 centimeter, they carry a significant risk of harboring occult malignancy or a intramucosal carcinoma. So this was the histopathology. You can see in the upper figure that there are the villous projections seen. So it's a villous adenoma, and in the hyper you can see that the nuclei are going up above the basement membrane, and they are showing some rounding of the nuclei. So these all are features of dysplasia. And still hyperview, which was a critical finding, that was a lamina propria, and you can see some of the nests which are infiltrating into this lamina propria, but not in the submucosa, and you can obviously see some degree of dysplasia here. So a focus of invasion in the lamina propria, which is called T1S, and the key histological features, that the small regular clusters of dysplastic epithelial cells breaching the basement membrane and with the desmoplastic stroma. So, with these findings, a diagnosis of dysplastic villous adenoma and invasion into lamina propria, which is called TIS, was made. So, before directly discussing this entity, I would like to draw your attention to the layers of the colon. So, there are 4 layers in the colonic wall. These are mucosa, which in turn is comprising of epithelium, lamina propria, and muscularis mucosa. Then second layer is submucosa. Third layer is muscularis propria, and then the serosa. So why lamina propria invasion matters? Because the colonic mucosa, it lacks the extensive lymphatic network. So if a lesion is invading into lamina propria or muscularis mucosa, it has virtually zero risk for the regional lymph node metastasis. And according to the AJCC and TNM guidelines, this is classified as TIS, that is carcinoma in situ, and not as T1. So these are there are 3 types of adenomas histologically. They are tubular adenoma, tubulovillous, and villous, depending upon the proportionate amount of the villous and the tubular component. So this particular is a villous adenoma because more than 75% of the lesion was having a finger-like fronts. That is a villous projection. So the clinical implication and prognosis, that it has got a very good prognosis, still it is invading only lamina propria, and the risk of metastasis is almost negligible. Clinical and surgical management, that endoscopic mucosal resection is quite possible, and if the size is more than 3 centimeter, organ preserving endoscopy with local excision is preferred initially, provided you got the clear margins. So this is how we differentiate between the TIS and T1 staging. And in TIS, it is just invading into the lamina propria, as I have told just now. And in the T1, it is going up to the submucosa. And that is a full-fledged invasion into the submucosa. And because there is negligible lymphatic network in the colonic mucosa, and which is seen in abundance in the submucosa, there are chances of the more regional lymph node metastasis in invasive, that is T1 carcinoma. Metastatic potential is virtually zero in the TIS, and the clinical treatment is local excision, is curative if you can get a clear margin. So the risk of malignancy in the villous histology is more than 35%, and for the polyps more than 2 centimeter size is approximately 40%. So this is the surveillance protocol which is to be followed. Now, after 1 year, the mandatory repeat colonoscopy to check for the local recurrence at the resection site. After 3 years, a 1 year follow-up is clear of any high-risk adenoma, and on 5 year standardized interval for the surveillance if prior examination show local low-risk findings, and the long-term standard screening protocol based on the future findings. So, are genetic tests required for villous adenomas? Then the answer would be that for a solitary lesion at the age of 70, like in this case, which is considered to be the sporadic case, no current criteria for the APC or LS germline testing unless there is a strong family history. So the MMR, which is mismatched protein overexpression, this is recommended, and the universal link syndrome screening is performed for all the carcinomas, including TIS at many centers. So margin analysis is essential, which is a mandatory thing, and it is more critical than germline testing for a specific patient's clinical outcome. So the conclusion or the take-home message from this case is that a 3 centimeter rectal villous adenoma, which is invading just into the lamina propria and not into the submucosa, it carries a high malignant. It does not carry a high malignant potential, and it highlight need for the complete en bloc excision whenever feasible. So invasion limited to lamina propria is histologically called intramucosal carcinoma, but clinically they behave as carcinoma in situ, and conservative local management is therapeutic. Aggressive radical surgeries are to be avoided unless the submucosa invasion or a positive margins are confirmed. Thank you.